Approach to the patient with red eye. When the patient presents to you with red eye, the first question you have to ask is whether it is painful, whether there is painful loss of vision, sudden painful loss of vision or not. If the answer is yes, then first you have to rule out the most dangerous condition, that is acute congestive glaucoma, for which you have to do intraocular pressure measurement. By tonometry, it will be greater than around 45 if it is acute congestive glaucoma. In the pupil, when you look at the pupil, it will be not responsive to the light or accommodation, and it is in mid dilated state. So this is because of the ischemia due to the acutely raised intraocular pressure, which compresses the vessel of iris. Now for mid dilated, you will give the pupillary constrictor as a drug as a treatment. If IUP is normal, then you have to rule out the acute iridocyclitis by looking at keratotic precipitates under the slit lamp. If keratotic precipitates are present, then diagnosis will be acute iridocyclitis. It will proceed like this, and the pupil will not be responsive and it will be in constriction. Now the constriction is due to the inflammation of the pupil. Now we have to differentiate between these two conditions, because if this is iris and we have the cornea and the angle and drainage of aqueous humor. In acute congestive glaucoma, the angle is narrow, so we have to constrict the pupil so that the angle will be opened. But if we misdiagnose acute congestive glaucoma as acute iridocyclitis and we relieve the constriction of the pupil and by giving the pupillary dilating drugs, and the actually patient is suffering from acute congestive glaucoma, so we further by relaxing the iris we further close the angle. So misdiagnosis can lead to the blindness and it will precipitate the acute congestive glaucoma. Reverse is true for acute iridocyclitis. So these are the most important diagnoses of painful loss of vision and red eye. If both are absent, then look for the history of perforation, for example in cataract surgery or perforated corneal ulcer or perforated trauma. Perforation will lead to the entry of exogenous infection into the eyeball and lead to the endophthalmitis. In the endophthalmitis, an exudate is formed in the vitreous body, so we do not see the red reflex, it will be absent, and the whitish reflex will be present instead. Now if after the painful loss of vision you make any one of the as a diagnosis, then the differentials will be these four: 1, 2, 3 and keratitis. These four will be the diagnosis, and the definitive can be made by these signs and symptoms. Now if all of these things are normal, then the diagnosis will be keratitis. Since keratitis is a very broad term, it has further subtypes. The first one is viral keratitis, then acanthamoeba, fungal and bacterial keratitis. Now how we will make the definitive diagnosis? For viral, look for the history of the immunosuppressant drugs, so that viral infection easily occur in immunosuppressive drug or other immunosuppressive conditions. Then in the viral, when you do the Reus Bengal or the fluorescein dye staining, then you have the dendritic ulcer, and the virus will decrease the sensitivity of cornea by destroying the sensory nerves. So we have the decreased corneal sensitivities. Corneal sensitivity will be decreased, so corneal reflex test will be diminished. If all of these things are normal, then you have to look for the other history, that may be swimming and contact lens and swimming. Since acanthamoeba is present in the pool water or mostly in the water, so we have the history of swimming, and the contact lens will provide the adequate environment for the growth of this acanthamoeba, and the patient will come with complaint of very severe pain. And when you look at the eye, the cornea is not as much in damage, so we have the out of proportion pain as compared to the actual injury. This out of proportion pain is due to the involvement of the corneal nerve, so we see the thickening of the corneal nerve, and the epithelial inflammation will form some pseudo tree branching pattern. It will not be true dendrite, so it is pseudodendritic ulcer. And in the periphery of the cornea, you will see the in late cases you will see the abscess, which forms a ring, mostly in whitish pus like ring, that is ring abscess. If both these are excluded, then go for the history of vegetative trauma. If you have the history of the vegetative trauma, almost always it is fungal keratitis. And when you look at the ulcer, there will be satellite lesion around the margin of the corneal ulcer. These satellite lesions are present due to the deposition of the fungal hypha on slit lamp. If none of these condition is present and still it is keratitis, then it will be bacterial keratitis, and mostly the ulcer will take 2% fluorescein dye. If you diagnose the case of keratitis, then the differentials will be these 4. Now, if the answer to this sudden painful loss of vision is no, there is no painful loss of vision, but there is red eye, then you have to look at the redness. If the redness is diffuse, all the conjunctiva is red, then it is conjunctivitis. And if the redness is not diffused, it is limited to one of the quadrant, then it is episcleritis. Now, like keratitis, if you diagnose the conjunctivitis, then the conjunctivitis is a broad term again. You have many other subtypes in the conjunctivitis. The most one are listed here. These are differentials of each other. Now, these are bacterial conjunctivitis, viral conjunctivitis, and the allergic conjunctivitis. First of all, you have to look at the exudate. If there is pus in the exudate, purulent, whether it is mucopurulent or totally purulent, then it will be bacterial. If the discharge is watery, it is viral, and if it is mucoid, then we have the allergic conjunctivitis. The next thing you have to look for is papilla. Papilla is a prominent feature of allergic conjunctivitis. What is papilla? Papilla is actually due to the chronic irritation. There is a fibrovascular proliferation that leads to the formation of finger-like projections on the conjunctiva, palpebral mostly, sometimes on the bulbar conjunctiva, but whenever you see this, mostly it will be allergic conjunctivitis. Then if you have the viral conjunctivitis, for the viral conjunctivitis you will not see the papilla and not in the bacteria. Next will be the follicle. Follicles, actually these are the tiny elevations present on the conjunctiva due to the lymphocyte proliferation. So the lymphocyte reaction against which of one of the following the lymphocyte will come to attack on the causative agent, that is virus. Against the virus we have the lymphocyte as a defense mechanism. So lymphocytes are more prominent in viral conjunctivitis. Follicles. So follicles are mostly absent. Sometimes in severe condition of the bacteria they may be present, but they are very important for the diagnosis of viral and absent in the allergic conjunctivitis. Next you have to look for the membrane. If the membrane is absent, may be absent in all the cases. If present in the bacteria, then it will be true membrane, and diphtheria, specific type of bacteria, that is Corynebacterium diphtheria, will form the membrane. And if it is present in the viral cases, it will be pseudomembrane, and the specific type of the virus in which the pseudomembrane is present is adenovirus. What is the difference between true and membrane and the pseudomembrane? True membrane is tightly adherent to the underlying structure. It will not be easy. It is difficult to remove the membrane, and if we remove it, it will result in bleeding. Pseudomembrane is not tightly adherent, and it will easily can be removed, and there will be no bleeding. But in allergic, there is no true or pseudomembrane case. Lymphadenopathy, again, it is a prominent feature for viral keratitis, conjunctivitis, not for the other one. Sometimes in severe cases bacterial conjunctivitis may present, but it is mostly absent. So this is how we will approach the different cases on the basis of the severity and the signs and symptoms and the